holding today in partnership with our co-host, MSD for Mothers. I'd like to thank all of you here who've joined us in person in New York, as well as those joining us virtually all around the world for this event, which is being held as part of Devex's Universal Health Coverage Pavilion. Before we begin, I wanted to just offer a few sobering statistics on maternal mortality. Most of the women in the world who die from pregnancy and childbirth are from low to lower income countries. 94%. That's the maternal mortality rate. It's a staggering figure, but what's equally disturbing is that most of these deaths are preventable because the solutions are well known. But this requires access to high quality, skilled healthcare professionals during childbirth. The SDG target for maternal mortality is reducing deaths to less than 70 per 1,000 live births. Many nations are far off that target, especially those in sub-Saharan Africa. The problem, of course, has been compounded by the pandemic, which has diverted resources from already strained healthcare systems. To tackle the problem, our co-host today, MSD for Mothers, launched a new initiative in September 2021, Strengthening Systems for Safer Childbirth. It's designed to achieve SDG 3.1 by investing in locally led coalitions to strengthen healthcare systems in India, Nigeria, Sierra Leone, and Kenya. So to kick us off, I'd like to welcome Dr. Marianne Itiabet. She's the lead of MSD for Mothers to the stage for a few remarks.
Thank you. There's a lot of energy in the room, so can I get a woohoo? Okay. We are so excited to be here. For those of you who know us, you know that we celebrated our 10th year anniversary last year, so we're actually having a little birthday this month. And on that 10th anniversary, our new CEO, Rob Davis, reaffirmed our company's commitment to helping end preventable maternal deaths and making sure that no woman dies while giving life. It was an additional $150 million to make sure that we were helping to get to those SDG targets and getting to 25 million women by 2025, ensuring all of them have access to high quality, safe, and respectful care. And we think that the vehicle we're going to get there with is through the coalitions that you are going to hear from today. There are 6 of them. They are going to be the inaugural cohort of Strengthening Systems for Safer Childbirth. And I am just so excited that we are going to be able to become part of their community and learn from what they are doing on the ground and how they are listening to women, integrating their needs, their preferences into their solutions, supporting horizontal integration across the ground, because we do know that there are not enough resources to go around. So we have to make sure that every dollar counts. I do want to say that while we are hyper-focused, on getting to those targets, it also matters how we get there, the journey. Making sure it's an inclusive one, making sure we are working in a way that surfaces diverse voices, making sure that we leave our partners stronger than when we found them, and making sure that we are investing in people and local institutions that will support sustainability of impact for the long term. And that's why I'm just so excited about this journey. I'd like to also take a moment to thank the team. It wasn't easy to get here. We actually, challenged ourselves to do things differently. And I'd like to just thank all of you for putting in the hard work to do that. Also for our leadership, we have our VP of Social Business Innovation here, Carmen Villar. So thank you for all your support. I see, just turned in, Naveen Rao. I had to give a big shout out to him, who, we're all standing on the shoulders of giants here. And with that, we will get to a place where no woman has to die while giving life. So thank you so much for joining, and for those who are joining online.
Great. Thank you so much, Marianne. We appreciate it. We're going to go straight up. So we're going to go straight into a one-on-one interview. We have virtually Cynthia Kawambara. She is the Kenya Country Director for Jacaranda Health, which partners with governments to deliver affordable and scalable solutions through government hospitals where the majority of underserved mothers and babies receive care. So Cynthia, thank you so much for joining us today.
Thank you, and I'm really delighted to and honored to be here with the interview and to join virtually.
Great. So, well, let's dive in. Cynthia, what do you see as the biggest threats to achieving SDG 3 targets in Kenya?
Well, currently, right now, based on our 2030 SDG targets, we're actually currently a double where it should be. But we have made some strides. And on the one hand, we've been able to see access has clearly increased. And we're seeing more Kenyan women are now choosing to deliver in facilities than ever before. And the government, through universal healthcare coverage, has actually implemented a national insurance scheme called Linda Mama that improves equity in healthcare access by offering maternity and newborn services for free, whilst reimbursing the facilities delivering these services through claims. However, on the other hand, a significant impact has been really in the quality gap in the health system, and which has been stalling our progress. And we've actually been seeing in recent years that the maternal mortality rate has actually across the country plateaued. And this has, as mentioned, has really been around, and I think you mentioned earlier, you know, not just access, but being able to receive high quality services during childbirth.
So now, to follow up, can you talk to us about this quality gap, why that is, and what you're seeing play out on the ground?
Yeah. So we see a couple of major issues driving this quality gap, but really it's mainly around resource allocation and also data collection. Most underserved women are supported by the public health system, but under 30% of counties' health budgets actually goes towards these public facilities that are providing these services. Local governments have available resources, but they're struggling to identify and use the resources available to them to efficiently and effectively prioritize MNH health system strengthening to really impact these maternal mortality outcomes. And we've actually been seeing finances financial revenues being collected from health services and being redirected into other sectors such as infrastructure instead of being plowed back into the healthcare system. We've also seen that money is actually being left on the table. As I mentioned earlier, you know, Linda Mama, which gives counties and facilities this additional revenue stream to plow back into improving quality, they actually are not fully utilizing it. For example, in Kakamega County in 2020, primary care facilities only claimed 15% of their potential revenue. And what does that mean? They were actually leaving $2.9 million on the table, which could have been reinvested in improving quality of care. The second aspect is, as I mentioned earlier, is really lack of visibility into collated data across the whole health system and the mom journey, really from ANC through to delivery and PNC. And some of this data is around emergency transport, blood supply, and also quality of care. This is not to say that the data is not being collected. It is being collected, but it is being presented in silos. And from this, what we're really seeing is around another big gap that we've also identified has really been the the absence of client data. And really, this is where the mom's voice comes into it and what they are experiencing in terms of services. And in Nakuru County, we actually have our head nurse in a high-volume facility called Christine, who didn't quite understand why her patient numbers were dwindling. And it wasn't until we introduced our digital health tool prompts that she was then able to see what's actually happening on the ground, and be able to reference the data around what are moms saying when they attend their ANC visits, ANC and PNC visits, and also what's happening at the delivery. And once we provided Christine this data, she was actually able to link reported cases of abuse with specific providers in her facility. She was also able to dig into the insights and learn why were clients struggling to make their appointments, and what was happening also in terms of service when they do come and experiencing long waiting times. And it's through this issues that she was being able to identify these issues, that she was actually able to resolve them in a low cost and low resource way, and actually see her volumes and her quality of care scores improve by 40%. And therefore, we're really seeing by combining these key data insights coupled with financial resource allocation, we can see facilities and counties actually improving in their quality of care services.
These are an interesting mix of problems, leaving money on the table, lack of data that I'm sure are relevant to so many different organizations. To wrap up here at UNGA, if there's one message you wanted to send across, a call to action, if you will, what would it be?
For me, it would be, we hope to really see a more integrated approach towards building health systems, and a shift from donors, local governments, and private partners such as ourselves, working on the different pieces of, shifting from working on the different pieces of the health system in silos, but actually combining our solutions. And we're already seeing, the establishment of communities of practice and various other initiatives, which actually involve the three key partners. And really for us, our first ask is looking, seeing continued investment in innovative M&H solutions as the building blocks for really building this resilience around building health systems. And in the recent past, we've actually seen donors are reluctant to fund health systems as a whole because it's too broad. But we're excited to see organizations such as MSD really thinking about this and explicitly funding it through the strengthening systems for safer childbirth. And also working a lot with locally established and embedded organizations such as ourselves to join forces and address often siloed issues that mothers are facing across the health system, and bringing them together.
Great. Thank you so much, Cynthia. And on that note, next up, we're going to present a video. I believe that also features you, which where we'll hear the voices of the partners and the healthcare workers from the new Strengthening Systems for Safer Childbirth, talking about what women in their communities need for better maternal health.
Thank you, Anne.
It is a well-known fact that in resource-constrained settings and adverse or suboptimal socioeconomic situations, women are the last in the line to access healthcare, and this impacts maternal health and maternal outcomes. So, in an attempt to address this issue, our coalition has developed a low-cost, digital solution under the Strengthening Systems for Safer Childbirth initiative. And we are hoping that this initiative will give women greater autonomy to access healthcare with full right and dignity.
We leverage existing resources and partners, but for the first time, give them a centralized tech platform and system to access emergency help and assistance. Before our services existed, millions of mothers had no guaranteed way of getting to a hospital during childbirth or moving to a more advanced facility when complications occur. Through partners, we've massively reduced the response times from days to minutes. In being part of the Strengthening Systems for Safer Childbirth initiative, we look forward to touching the lives of women and communities, giving 100% guarantee to women that they have access to transport during an emergency and solving the second delay, which will become a model for other countries. We are thrilled to be part of this amazing network of changemakers and get to learn from other incredible organizations all working towards reducing maternal mortality.
Now, Sierra Leone has one of the highest maternal mortality rates in the world, but nonetheless, we're always striving to find ways in which to improve and to reduce on that. And we're hoping that this coalition would bring together different aspects, each with its own speciality that would talk directly to reducing maternal mortality.
Women's voices, agency, and participation will be incorporated into every aspect of this work using Navios AI, a digital patient review and referral platform which will bring transparency into women's care experiences and incentivize healthcare facilities and regulatory agencies to understand, analyze, and act on women's feedback. An enabling ecosystem will also be created that will sustain women's participatory engagement over time while also improving experience and quality of care so that no woman dies while giving birth.
What's exciting about this project is its potential for broadly rethinking the way we address maternal and newborn health. We also see it as a springboard for broader health systems impact, creating a blueprint for counties across Kenya to invest in high-impact solutions which incorporate the voice of the mom and support data-driven decision-making to improve the way maternal and newborn health services are delivered.
The women's voices, it has to be sustainable. You have to make sure that you have a finger on the pulse of the needs of the women. That's why it's important that we include women's voices, and women's voices, their inclusion ensures the sustainability of the project because the health facility can adapt to the needs of the women easily. So we are very excited to be part of the Strengthening Systems for Safer Childbirth initiative because of the incredible access that we'll have to MSD for mothers, partners, and across the spectrum.
So welcome everyone. I wanted to do a quick introduction. We have Dr. Ben Nikichika. He is Director General and CEO of the Delta State Contributory Health Commission in Nigeria. We also have Nirajan Sagurti, Director of the India Office for the Population Council, which conducts research and programs in more than 50 countries. And we have Natasha Sundarji, who is the Global Health Lead for Accenture Development Partnerships. So thank you everyone for being with us here today. And also before we begin, we will have time for an audience Q&A after. So if you have any questions, begin to think about them. So I wanted to start by asking each of you about your efforts to achieve SDG 3. What have you seen work? What have you seen not work? And include any examples of any evidence-based solutions informed by local community decisions that you have been able to implement. Dr. Ben?
Thank you very much. Achieving one of the SDGs is ensuring people have access to quality care, but particularly for the most vulnerable people, the pregnant women and the children under 5, who basically determine a significant part of the health indices. So in Nigeria, there is the program to ensure that not just the providers being available, but the people being able to afford care. And what we noticed was that in some communities, there are facilities that are there, but the people can go there because they can afford to pay. And in some communities, the buildings are there, but the facilities are not functional. So the women, the children, and the other people there are now exposed to the unorthodox healthcare services, the healers, the traditional birth attendants, who basically set up a high mortality situation. And there's an example of a community called Polobubo. It's about 4 hours by speedboat in the Niger Delta jungle. And where I was approached that they had a facility built 25 years ago, and they have never had access to quality care. And getting there, we realized a significant population were pregnant women, children under 5, but basically women, because the adults and the men usually go to the urban centers to look for resources to be able to come back. So you see a community population where 80% of them are just women. And then we realized they didn't have care. So we devised an access to finance program to get private sector to go in there to deliver, to provide the service. And they were quite happy because we have a health insurance scheme. And in the health insurance scheme, we said all pregnant women, children under 5, they're able to walk into a facility, get healthcare free of charge, and automatically registered into the health insurance scheme. Over time, antenatal was good, but when it's time for delivery, we just don't find these women anymore. And we tried to find out what was going on. Everybody was silent. Nobody wanted to tell us. So I organized a football match with the children, and while the game was going on, I sent my people to privately go into the houses to ask. And they said, oh, there's this woman who is a traditional ruler, and she says that if any woman is giving birth and somebody sees her and the person has an evil spirit, the evil spirit will affect the child. So basically, she's the only one that sees a pregnant woman delivering, and whatever she comes as I say is the outcome is what's the outcome. So you can imagine a multiple pregnancy or any complicated pregnancy is obviously a bad situation. And we tried to intervene. We're told, don't even bother because she's reverenced as a healer and all that. So what did we do? So we identified the problem. So we got in a retired matron, and we told them this matron also has spiritual powers. And we set up a section of our clinic and said, if you also come there, you will receive care in the same way from this spiritual lady, but nobody will see you. But obviously we have our doctors go into the back door to go attend to them. And that happened, and we started having successful deliveries because it gave birth to people, it gave a situation where people walk in, receive care, and give birth. Now problem 2 came up. We had a male child, and we did circumcision, and within a short time, the wound healed. And they were like, oh, majority of the women, when they deliver in this traditional healer's place, the children always end up in neonatal sepsis. So there was a high mortality. So a lot of the women stopped the children from being circumcised. So we're now having 15, 20, 30-year-old boys coming to get circumcised. That also became a positive outcome. And currently, since we started this intervention, we haven't lost any woman. Thank you.
Thank you. Thank you. I wanted to turn it over to you, Nurjan. What are some of the things that you've seen?
Yeah, thanks so much, Anna. Let me put the numbers first in terms of what we have been seeing in India. Annually, around over 35 million women become pregnant and result into approximately 28 million live births. And what happened in case of India was that there has been a lot of effort from both the public health system and also from the private health sector. Most of the antenatal care happens in the private health sector. And when it comes to the institutional deliveries, there are a lot of deliveries that are taking place in the public health system. While India made a substantial progress in reducing the maternal mortality from about 300 deaths per 100,000 live births in 2000 to 113 deaths per 100,000 live births in 2018-19. But that progress is not uniform across the country. There are some geographies, some states, some specific population subgroups where the maternal mortality is continue to be high. For example, in the state of Assam, where our coalition has proposed to work, the maternal mortality is over 200 deaths per 100,000 live births. So the problem is multifold, and it's contextual, and it is very local from the perspective of the problem. There have been number of initiatives, as I said, the public health system has taken to improve the quality of care within the health facilities, to improve the delivery experience. There were a number of initiatives, as my friend from Nigeria also mentioned, about the kind of initiatives that the government has undertaken. While it all has addressed the intrapartum care element of the overall care, there are these other contextual, the antenatal and postnatal care is continues to be a challenge. For example, in India, the recent statistics actually suggest that only 50% of the women receive 4 or more antenatal care checkups. So the problem exists there. So there are some initiatives that have worked, and the initiatives that to improve the public health sector from the service point of view have addressed only a section of the population group. It's not, there is no platform or a place where the women, providers, and everybody can get together to work. And those are the elements that we need to continue to work on this. Thank you.
Thank you. And Natasha, turning it to you, what are some of the things you've seen?
Sure. So perhaps I'll just put Accenture into context here. So global health has always been a big priority to Accenture and to Accenture Development Partnerships, which is the social impact arm of Accenture. Over the past 20 years, we've done over 2,000 projects and programs in partnership with so many fantastic organizations that are in the room today working across 90 plus countries. Our priorities have always been on health equity, strengthening strategic partnerships, so how you really bring together disparate actors to have collective impact, and looking at the next frontier of digital health. Now, when it comes to SDG 3, I think we should all take a moment to reflect on and be proud of the progress that we've made as a global community. We have done so much together. But as you rightly pointed out at the beginning, the current ways of working are still leaving many people behind. I think you even quoted the stat that in Africa alone, we need to double the rate of progress if we hope to achieve our maternal mortality target of having less than 70 deaths per 1,000 live births. So what do we need to do differently? To me, I think it's about 2 things. The first is improving the ways in which we address human-centered design. So over the past decade, I think human-centered design, people-centered design, putting the individual at the center has become part of all of our lexicon. And we've certainly seen how that's helped us to accelerate our programs, strengthen the ways in which we embed these within local communities and get to a level of scale and sustainability. What's not well known is that across many markets during the pandemic, patients, individuals, communities actually lost trust in healthcare companies. So if we really want to address those that we're leaving behind, we really have to work hand in hand with them to rebuild trust if we hope to rebuild health systems. The second big thing I think we really need to be thinking about is localization. I'm so excited to hear so much more discussion around localization from so many big funders to really put the power back in the hands of local organizations that really understand the local context and the local challenges. We see our role as Accenture as being what we call a global partner. So bringing in local individuals that can help to support and mentor and coach and create connections for these coalitions in Kenya, in Sierra Leone, in Nigeria, in India. But then using our global footprint, our global voice to help elevate the learnings that they're experiencing and seeing on the ground to the regional level and to the global level, so that as a collective community, we can advance global health and maternal health.
Well, thank you, Natasha. And on that note, bringing up the issue of localization, I'm sure you've heard the term a lot this week and in general, obviously such an important thrust in global development and the global health space where everyone's trying to shift from these funder-driven priorities to locally driven priorities. So Ben, I wanted to go back to you. What do you think needs to happen to ensure that this rhetoric turns into reality?
First of all is to actually identify the needs of the people. From experience, what usually happens is healthcare solutions are designed with other people getting involved, and you send it to them, it doesn't meet their needs, so they just reject it. So first is identification. of the actual need of the people. So you need to go there, sit with them, understand their peculiarities and their desires, and then you meet them at that point. Next is to develop a strategy that also delivers their need to them. So if you have a need, but your strategy does not deliver that need to them where they are, you're not going to get any outcome. And the next is now what process keeps it going to ensure that not only do you deliver your strategy, there's a process that ensures continuity, and then you take actions that have the people as a component of it. I got a very interesting question one day where somebody asked me, you are doing all this, when you leave the health insurance scheme, what happens? I said, before I leave, the people will take ownership. So anybody coming back to say he wants to stop it will have to deal with the people. And when the people take ownership of it, it always works. We've even found out a situation where we are now sitting in our office and various kings and traditional rulers from across Delta State are now writing to us, oh, we have identified a facility in our community. We want you to come and do that. We currently have 15 operational. Thank you.
Thank you. John?
Yeah, thanks so much for that question. Because the solutions that currently we have is more of the facility-centric, more from the point of view of the medical care. But what we don't often see is what women want and what kind of services are we not addressing at the field level. That's what our coalition, which I'm representing from India, is trying to do, is to create that marketplace where NIVI is a platform, and on that platform, the consumers, the providers, the stakeholders, the insurers, the marketers all come together and create an opportunity to reach every woman in the community. Today's solutions target only a specific section of the population groups, and if we want to really address that last mile to reach the SDG goal in India, or in the geographies where there have been a lot of challenges in terms of the field for women to access the care from the appropriate, when I say the access to care, access to appropriate care. What we need is how to bring all women in that local geography and connect them, give them the appropriate information, connect them to that geo-referenced healthcare facilities, so that there are no further delays that are happening to get to the better care. And the early the women get to the care, the better it's going to be, both from the self-care point of view and also from the quality of service that they can receive. And that's what we need to do. If we need to kind of achieve the SDG goal, we need to identify where the gaps are, how much do we have the inequities in terms of, and which population subgroups are actually getting the care and who are not getting the care, and what the realities on the ground, and understand those realities and take appropriate action. And that's what our coalition is trying to do.
Hey, Natasha, what are some of your thoughts?
So if we really want to move away from funder-driven priorities to locally driven priorities, we need to fundamentally change the power dynamic that exists between funders and grantees. Said in other words, if we truly believe that community-based solutions are the ones that are most likely to succeed, to get to scale, to be sustainable, we got to put our money where our mouth is. We've got to direct the funding to the local organizations that are deeply embedded in the communities, that have the local context, that have the local relationships, that have the local understanding that's going to allow them to be successful, to really allow them the space to figure out what they believe will work and give them the space to correct their solutions as they learn more, and even giving them the space to define their own metrics of success. All too often, we come in with a preset or a set of defined indicators that aren't always fit for all purposes and fit for all solutions. So I think we need to give local organizations the power, the funding, and the space to be creative and do what they do best.
Natasha, I want to stay with you to talk a bit about the importance of community of practice. You ideally have these lessons learned from various organizations on the ground, and then you want to elevate that and scale it up on the global level. So can you talk a bit about that, the importance of learning those lessons, of expanding on those lessons, and just organizing what is happening on the ground?
Sure. So, one of the unique things about the S3C program is that we are creating a community of practice amongst all of the coalitions so that we can create connections between them, so that we can give them an opportunity to share the challenges they're experiencing, to share learnings across geographies, and to give them the space to elevate what they're learning to the regional and to the global level so that we can collectively advance our efforts around maternal health. These kind of platforms are so incredibly important because all too often, I think we fail to recognize the competitive nature of the international development sector. We are all competing for limited dollars, and it makes it very difficult to incentivize different organizations and coalitions to be honest about the challenges they're experiencing, their learnings, because information is power. What I'm so excited about that's different about the S3C program is that these coalitions have a guaranteed line of sight to funding for 3 years. We've removed that competitive barrier that prevents people from sharing. And so this community of practice, we hope, will help them to have that space, that trusted space where they can actually share their ideas, share their learnings, and hopefully collectively advance their efforts towards maternal health.
I think that's really interesting, the point that you raised. There is this level of competition in the international development sector, and collaboration, and more importantly, coordination is so important and is sometimes lacking. Ben, to follow up, what are some of the things that you've seen, and how do you think we can move into putting in practice, kind of bringing in these disparate actors on the ground?
We are in a peculiar situation where we operate from the government service position. But one very significant experience we've had is that the people are usually aware of what they need. There are several organizations around them that have the desire to help them get what they need. There's also a supply side deficiency because no matter the advocacy, no matter the process, the system you put in place, if that man or a woman is not able to walk into a healthcare facility and receive the care he or she needs satisfactorily, it's going to tell the next person, don't go there. And you find a situation where there's always an alternative unorthodox healthcare system in those communities. And once the normal system is not working, you leave them to that, and those challenges are there. So what is best is, first of all, proper education, letting them know that these facilities are there, those facilities will be improved, enhancing that capacity for the facilities to be open to provide care, and then building the confidence of the people so that when you go now to intervene and let them understand the peculiarities of and the importance of better health seeking behavior, there's also that supply side to deliver. Another very significant experience I had is that you even see a very serious situation where people have healthcare challenges. They sell their clothes, they sell their farms. You know, they have to go into poverty or debt to be able to get healthcare services. So there must be an intervening factor where people don't have to experience that hardship of either taking a loan or selling their property. And what we've done in Delta State is that as soon as we identify that program, we basically put a mandate that if anybody is able to walk into a healthcare facility and is unable to afford the care, please provide care. The health insurance will pay for it. But to check the abuse, we also make sure that we have a feedback mechanism of confirming that that situation is not abuse. But particularly for pregnant women and children under 5, it's helped a lot, it's improved the health outcome. In fact, we currently have a problem where majority of our maternal cases are actually people that are coming from other states. So you see a situation where maybe in Anambra State, neighboring states, a cesarean section is about 150,000 naira or 250,000. I don't know how to convert that to dollar immediately. But so the woman goes to her state, registers for antenatal, also comes to Delta State, registers for antenatal. As soon as there's a diagnosis of you're likely to have a CS, she just transports herself to Delta State, because in Delta State it's absolutely free of charge. The outcomes are better, while in her state she has to pay 250,000. So we're even having that situation. And initially we're like, why not prevent that? But we said, if we do that, that woman is going to have a catastrophe. So we've decided to let it open, but find ways to accommodate it. So ensuring that systems, processes are in place that are integrated, that deliver the service and also provide a confidence for the people to seek that service is first important. Thank you.
Nirajan, what are your thoughts on some of the challenges of collaboration and coordination?
So the challenges is one of the biggest challenges that everyone in the system like to work independently, and they're very good at it in terms of in implementing the individual solutions or the individual programs. The key challenge is to how do we build that trust between the sectors and build the trust between the health system to the communities and to the individuals at the local level, and how and what kind of communication can that go on from the taking the feedback from the woman to inform into the to improve the system. There are lots of those challenges to work on. The idea is how do we connect these different actors who can make the difference, real difference, at the same time have the voices being heard from the local communities, the women's voices integrated into the improvement of the quality of care. That's going to be critical, and that's what I would say. Thank you.
So I wanted to wrap up and ask each of you, we're going to still hear a lot of speeches and talk this week and did last week as well. What is what do you want to see coming out of UNGA, specific call to action? Ben?
Well, is to, first of all, create more situations like this where real examples of what's going on are brought out, and also to now take on the outcomes of this and put it to actual practice. Because I've also had experiences where we've had panel discussions, a lot of decisions are made, but when it's time to take it to action, it becomes a difficult situation. So actions that are very simplified, very straightforward, but meets the needs for better outcome is what's most important, and I hope we get that out of this conversation. Thank you.
Nirja?
My message would be to say that hear the voices from the field, respect the women and children who have a lot to say about their future, and that's going to be my recommendation to UNGA. Instead of bringing in these international ideas, I think now it's a time for field to give a feedback to the international communities. Thank you.
Took the words right out of my mouth. I think the thing that I would like to see coming out of UNGA is a commitment for all of us to spend more time listening. We all too often come into these contexts with preset notions, preset ideas of what will work, what won't work. And we therefore are biased when we are listening to the people. And we hear what we want to hear sometimes. And I think if we were all a little bit more humble and really came in and listened, we would probably work better with communities. We would probably establish trust faster, and we'd probably get to the right solutions that are actually going to scale and be sustainable.
Thank you. Thank you, everyone. So I wanted to open the floor up for some question and answer. I believe we might have some, do we have any mics that will be going out? We do. Okay, great. If you could raise your hand, briefly introduce yourself, and let us know your question. No, we have one over there.
Thank you so much. Colin Haynes from Development Associates, LLC. Thank you, guys. This has been a wonderful discussion. I think one of the things we're seeing from a lot of our engagements is the need to really engage with our community. Do you guys think that in the international framework, there is a time now for us to somewhat take up an adaptive approach? Because we need to get out of this silo of thinking we know it all, as you're saying, Is there like an adaptive approach, do you think? And also along talking about prevention mother to child, I don't think we've also covered some of the mental health issues, that comes hand in hand as well, particularly in Nigeria. What are you guys doing with the intersection of like postpartum depression and so forth? What are some of your stories in India as well? We'd love to hear. Thank you.
Okay, thank you very much. Starting with your first question about adaptive situations, one other very important thing is to realize the fact that not one system works across everywhere. So when you are adapting, you have to peculiarize it to the actual situation in those environments. And then talking about depression and the mental health case, our healthcare system is collective. We are not just targeting the maternal care, from health education to contraception to the mental health care situation, post-op management, and the entire spectrum of healthcare services is all part of one benefit package, which we deliver across board. Thank you.
Yeah, from the context of India, I think the adaptive approach, I would echo to what Ben has said. The key is to make it more contextual on both sides, to hear the voices from the local communities, and at the same time to see how does that match with what the general situation or the learnings have been. On the postnatal depression and mental health, in India especially, we keep talking about it, but as a solution, we haven't done really enough. And the COVID has taught us that what the kind of mental health issues that the even general population face, and more importantly, the pregnant women and the new mothers have. And there is a lot more to work in that direction on the postnatal depression. There have been small examples, and what one of in our solutions is try to kind of provide that level of information. That's what so that we are continuing providing that continuum of information throughout, from the before, during to post delivery, the communication and information, and connecting the woman to the services. Thank you.
Maybe I'll pick up on that mental health point. I think as a global community, while we've recognized the importance of things like primary healthcare, we still continue to fund a lot of diseases in silos. And so we think about this woman as a pregnant woman or a new mother, and not just as a human being that has a multitude of issues, challenges, health opportunities that we can collectively support. This is why coalitions and partnerships and care coordination is going to be so important if we really hope to achieve and overcome the gap that we're seeing between where we are today and the SDG 3 targets that we need to get to.
Thank you for the question. I think we have one here with the microphone, and then we'll go there.
Hello, everyone. Hello? Okay, great. Thank you. And good morning, everyone. My name is Lisa Hilme. I'm Executive Director of Core Group. Great to see a lot of friends in the room. Thank you to Devex and MSD for convening this. My question is around communities of practice and collaboration. And I'm really happy, Natasha, you mentioned about some of the funding and financing inequity that happens for local CSOs, local engagement. So how can we, and there's a lot of local and regional CSO networks, as well as private sector networks, as well as the global that combine them both. How can we leverage, amplify, and collaborate more with organizations and consortiums that can really share the important work that you're all doing, as well as spread advocacy messages and really best practices technically, as well as for financing? So I'll stop there, and thank you very much for that. If you can solve the collaboration issue, I'll be very happy. Thank you.
Happy to take that one. And Lisa, I have to commend you and the Core Group for the fantastic work that you're doing to help bring together those communities of practice and to share learnings. I think collectively, as communities of practice, we haven't done a good job putting out the ROI of our efforts. So we know it's the right thing to do, but we haven't really quantified how that's helped us to accelerate our impact, how that's helped us to bring new and exciting and innovative ideas that have actually helped us to get greater scale and greater sustainability. I think more work actually needs to be done there so that we can collectively convince folks why it makes sense to invest in these communities of practice and how to do it right with the limited dollars that we have.
Now we have one person there with the mic, and then we'll go over there.
Great. Thank you very much. Thank you to the panel. I think it's really great to be talking about local solutions. And I hear the panel talk about listening to women. And I'm sure that we all know the impact of midwives, the impact that midwives have locally. So could the panel explain to what extent do they work with local midwives? Because those are those voices that you need, and their impact is huge. Thank you.
Thank you. Ben, would you like to begin?
Yes, the midwives are very important, and I will immediately categorize them into two sets. So you have the working midwives and the retired midwives. And as much as possible, we ensure they're part of it. So part of our strategy, we realize that in some government hospitals, due to manpower shortages, you find that there's a gap, and we've just instructed that any retired matron midwife within that community is immediately engaged and paid a stipend every month to provide either supportive care to the hospital or advocacy to the community. So we'll make sure we get them all engaged, and we'll provide a training for them to ensure that they're part of it and it's worked effectively. Sometimes when we even see situations where there's probably a traditional birth attendant or a spiritualist, in quotes, carrying out unorthodox practices, we engage those people to go in there because they are from the community and the women have been known to trust them effectively. So we use them as a medium instead of intervening directly, and that has worked. Thank you.
Yeah, thanks so much for that question. I think when we were talking about this digital marketplace, we were talking about engaging all the stakeholders, including the auxiliary nurse midwives and the other community health workers and the private providers and the other stakeholders that exist in the local geographies. The key for India, in case of India, as many of you may know, that the midwives trainings have started now. We don't have a formal cadre of the midwives in the country. There are a number of training centers that have set up, and the trainings have started. I see the point about how proactively can these midwives be engaged in this process, and having that appropriate communication be into that process. But that's a great point. Thank you so much.
And I think if we could get a microphone over here. Yep.
Hi.
We'll wrap it up.
Can you hear me? Thank you. This has been just an excellent panel. We heard a little bit earlier from Christine from Jacaranda Health talking about money being diverted to infrastructure that was meant for healthcare. But 59% of health facilities in low and income countries don't have reliable electricity, and health workers are needing to work by kerosene lantern, candlelight, holding cell phones in their mouth to deliver babies. So I'd like, and my organization is actually doing countrywide initiatives now to bring solar power to support safe childbirth. But I would like you to talk about maybe cross-sectorial, how do we work with other ministerials? How do we make sure that there is the infrastructure, electricity, water, so that health workers are not afraid to work at night, and patients are not afraid to come to health facilities that are
Thank you for the question. It was a very challenging experience. So before I started the scheme, I visited every primary healthcare facility, and something was evident. They all had candles, burnt candles and lanterns in the delivery room. And I asked why. They said majority of the women are farmers. So they go to the farm, even with their pregnancy. When they start having contractions, they manage the contraction till they're able to come from the farm, and they walk into the facility at night and they deliver. And that was the reason why that was happening. So what we've done is that every healthcare facility in Delta State has solar, and we pay for the solar power directly. So it has at no cost to them. And then those that have more needs to sterilize the equipment, we provide them generating sets and all that. So power is not a problem. We're even upgrading the solar power system to ensure that at least as a minimum, there's light 24 hours within all the facilities. Thank you.
John, just to wrap it up and get some thoughts on India context.
Just before this, coming to US, coincidentally, I was in Meghalaya, which is one of the states in northeastern part of India, and we were trying to study and understand the situation of the primary healthcare in the health facilities. And I was quite happy to see how the solar panels have been used as a mechanism to address this electricity challenges, and also a lot of equipments within the primary health centers need electricity and the power, but that's happening in some geographies. I mean, not many geographies, but the lessons learned from the government of Meghalaya, with whom we were partnering in understanding the effectiveness of this setting up solar panels and the improving the efficiency at the health facility level, is going to be important lesson for other geographies within India. Thank you.
Well, I want to thank all of the panelists here for joining us and for all of their insights. We really, really appreciate it.
Thank you so much.
And next up, I wanted to welcome to the stage, we have Dr. Austin Demby. He is the Minister of Health and Sanitation for Sierra Leone. Welcome. We have more microphones than needed. You can never be short on microphones. So I've also welcome Dr. Demby. You've been in your position now for nearly 2 years. What have you seen over these last 2 years at Sierra Leone? And over these last 2 years, I'm sure it was very interesting because all of that's been compounded by the pandemic.
Thank you very much, Anne. I've been in Sierra Leone for about 18 months now, so close to 2 years. And perhaps this has been one of the most exciting jobs I've ever had in my life. We have a situation where in Sierra Leone, you have one of the highest maternal mortality rates in the world, with 717 per 100,000 live births. At the same time, you have a country that's relatively small. It's about 5 to 6 hours from end to end, east to west, north to south. You have 7.5 million people in this one location. And so for me, I see this as a major challenge, but a great opportunity to make a difference. In my quest to meet the SDG 3 goals, I know that if we carry on business as usual, it's going to be nearly impossible. And so we have to institute some fairly radical changes to the way we do business. And I'm really pleased to hear people say, listen, and I'll add to listening, to hearing, and after hearing, acting. So we're determined in Sierra Leone over the next 3 years to reduce our maternal mortality from 717 to less than 300 in 3 years. So I was waiting for that reaction because in a lot of cases, people go like, wow, let's do it. And some people go, you crazy? But I think we're determined that in 3 years, we will move it down. And there's a strategy, maybe we'll talk about that later on. But I think if we get to less than 300 per 100,000 in 3 years, it sets up a really incredible opportunity to get it down even further before 2030.
Well, let's go ahead. Let's go into what are some of the strategies. That's obviously an ambitious target. What are some strategies that you plan on implementing or hope to implement?
So let me provide some context first. I think we have a situation where traditionally all of the programs are very vertical disease programs, malaria program, HIV, TB, malaria. And I think what we're trying to do in Sierra Leone is to change that paradigm. And when we say patient or client-centered care, what we're looking at is interpreting universal health coverage in our own language that we understand. For us, universal health coverage that underscores ensuring that everybody is considered, no one is left behind with providing high quality care. and ensuring that people don't go bankrupt because of a health event. Our approach to this is taking the life stages approach, starting with the pregnant woman. What programs and services do we have for pregnant women that will allow them to reduce this maternal mortality, not only looking at mortality, but also including improving healthcare for mothers till the baby is born? What services do you have for the baby? What programs do you have for the baby till they're ready to go to school? Early childhood development. What kinds of programs and services do you have for them till they're in school? What programs and services do you have for them till they're adults and they're senior citizens across the board? We look at it through a gender lens, we look at it through a disability lens, and we want to be sure that at every stage, I mean, some people call it life course, but we call it life stages because even though it's a continuum, we want gates, we want check-in points along the way to be able to see how things are going. So we've changed that approach to healthcare delivery, and we're very fortunate we brought everybody together in the country, including our development partners, Ministry of Health, civil society, traditional leaders, interested parties, to think about this as a nation. How do we move forward? And we have an aid memoir that's helping us track these changes going forward. But coming specifically to that first stage of maternal and child health, what we're looking at is we have a 5-point strategy as to how we could change this paradigm. First, we know that 14% of the maternal mortality occur in girls under 20. So 14%. So having a direct program that's focusing on reducing or removing or minimizing teenage pregnancy is very, very critical. So we're looking at sexuality education in and out of school. We're looking at commodities availability, accessibility for them. We're looking at, in fact, in Sierra Leone, we have radical inclusion, which means that you're not going to be penalized twice for being pregnant as a teenager. Will allow you, will work with you to safely deliver your baby if you choose to, and be able to come back to school. And a lot of this mortality occurs also because the girls tend to try to terminate the pregnancies themselves, and it becomes a crisis. And what we want to do is to encourage and support these pregnancies. But if you want to terminate the pregnancy, we want to have a safe way of terminating the pregnancy. So with these efforts, we think that we could, we could address the teenage pregnancy piece. And also, for young girls who may struggle to deliver, we want to have C-sections available to them as needed. And we're providing a lot of services for them. And the next stage is the next pillar for us is we have 1,500 primary healthcare units spread throughout the country. If you look at a heat map, it's evenly spread such that 85% of the population have access to a health facility. And so the important thing is, if you have access to the health facility, how come you have such really poor health outcomes for pregnancy? So we're looking at quality issues around that. So how do we ensure that, first, physical infrastructure, that this place is clean, it's tidy, it has a lick of paint, it has water, it has energy that's able to attract people to come in and deliver in these facilities. Second, we want to have a good mix of quantity and quality of providers, matrons, midwives, nurses, technicians, with the right training and the right complement of skills, but also with the right attitude. And thirdly, we want to be sure that they have the requisite equipment and supplies in these facilities. And at the same time, we want to be sure that they have the requisite drugs for it. We also have just developed a new app that will allow women to register their pregnancies by choice. If you register the pregnancy, it'll show you your geolocation. It'll let you see all of the facilities that are within a 5-kilometer radius of where you live. It'll allow you to pick your own facility where you want care to be delivered, and we'll engage a care provider for you upon a contact and engage the community with you. And the community will own that pregnancy. We're looking at an average of about 4 encounters with the health sector. We want to raise this to 8 encounters. And at every time we'll collect information, we'll collect data, and make sure that we can manage pre-existing conditions, we could manage comorbidities, we're able to anticipate problems and solve them, we're able to identify high-risk candidates that we could pay closer attention to. And the third component is having a referral system. a good ambulance system, a good network that's able to move people quickly. And a fourth is ensuring that if they go to the secondary and tertiary facilities with complex cases, that they're ready to receive these cases. The fifth in our 5-pillar approach is when you collect all of this data, it's available to you. I like to sit here and look at all of the pregnancies in Sierra Leone now. I want to know all of the deliveries that occurred last night. I want to know all of the difficult cases that we had before. And we'll have green lights for where it's all safe. We'll have amber lights where the challenges. We'll have red lights where there are challenges. I don't want to wait till the end of the month to find out that there's a problem. At the end of that week, we'll sweep the data and we'll see where we needed to provide more attention, more energy, more support. If it's equipment, if it's more training, if it's more additional staff, we'll make that available so that by the end of the month, we have a better view of what's happening nationally. We also want to make this available, transparent to everybody, and such that you have very subtle competition. So you have these communities of care in the different locations. How come PIH is in Connaught? What's the numbers? What's the outcome there? How do you compare it with the other districts in the country? So if you could see that information on a daily basis, on a weekly basis, it provides internal innovation opportunities. It provides ways of improving health outcomes. For us, the ultimate goal is to change these health outcomes. And what we're going to try to do is to set targets, specific targets for every community to see what you work towards.
Well, thank you. It's always good to hear such a detailed, specific strategy for such ambitious targets. So I want to thank you so much for outlining that for us and for joining us as well. We really appreciate it, Minister Demby.
So, and just lastly, Sierra Leone has got a lot of experience with emergency response, and we've done Ebola and COVID. There's some principles around emergency response that are really critical. So for us, we've decided that maternal mortality is a national emergency. We're going to apply those principles of emergency response, incident command, making sure you look at what's going on a daily basis and respond to it in real time to make the difference. Thank you.
Thank you. And I think that's Marianne. I want to welcome Marianne back to the stage. And I think that's such an interesting point that Minister Denby made, that we have to remember there are lessons that the US and other countries can learn from African countries and those in low to middle income countries. So Marianne, what are some of your closing thoughts here?
So first of all, I just want to thank all of you for coming and Dr. Denby. Thank you. My voice does not carry over continents. Okay, thank you. But just wanted to thank all of you who are joining in person and virtually, and really to follow up on what the minister said. Maternal health is an emergency. We need to maintain this sense of emergency and urgency in all we do, and not let that go. So thank you so much for emphasizing that. I also wanted to speak to, without leadership like yours, without government leadership to pull all of the disparate actors that are working on this issue together, we will get nowhere. And so I think it's really important that all of these efforts are all part of how we build capacity in mixed comprehensive health systems. I just, took some notes in terms of what folks said, so I'll be quick. I heard be humble. I heard listen. I heard act for impact. And as I reflected, I often think that when we listen, sometimes what we are asked to do are the simplest things that don't need 3 degrees. There are also sometimes things that are outside the health sector. There may be things that we don't have expertise or experience in. There may be things that we are uncomfortable. But just because there are all of that doesn't mean that we shouldn't do them. And I think, Natasha, you said there are a multitude of opportunities, to keep women healthy. And so we need to work collectively to do that, even if it's outside our comfort zone. And lastly, I want to say, hold us accountable and be radically inclusive. Thank you.
Thank you so much, Marianne. We, of course, want to thank MSD for Mothers, thank everyone in the audience, and thank our speakers. For those who are here in person, we encourage you, we have a White Ribbon Alliance booth, which you'll be able to find in the networking area. And please stick around. Coming up in 15 minutes, we have a session in partnership with the Sabine Vaccine Institute called Reversing Alarming Declines in Immunization. So thank you, everyone, again. Appreciate it.